Hi, my dear lovely friends. Let's take a look at the endocrine surgery. In endocrine, we'll be focusing on thyroid and breast. In thyroid, we'll be mainly focusing on goiter. Goiter is simply enlargement of the thyroid gland. And the reason is iodine deficiency. Whenever there is iodine deficiency, it will not allow T3, T4 to form. So T3, T4 levels in the blood will be less. And if T3, T4 in the blood is less, then hypothalamus will secrete TRH, thyrotropin releasing hormone, which will act on anterior pituitary to release TSH, thyroid stimulating hormone. And there are TSH receptors on the surface of the follicle in the thyroid gland. So this TSH binds with the receptors on the follicle, and this TSH has two functions. It promotes the release of preformed T3, T4 from the thyroid into the blood, and it causes enlargement of the follicle. Whenever there will be iodine deficiency, T3, T4 will not be produced, so blood levels of T3, T4 will be less. TRH, TSH levels will be high. This TSH is continuously stimulating the follicles to release T3, T4. But because follicle is not having T3, T4 because there is no iodine, so this TSH will start causing enlargement of the follicle. If all the follicles enlarge, this is diffuse goiter. And in diffuse goiter, if the patient comes to us, we can give iodine supplements or we can give thyroxine. If we give iodine supplement, T3, T4 will form in the thyroid, T3, T4 levels in the blood will increase. If we give thyroxine, T3, T4 levels in the blood will increase. If T3, T4 in the blood increases, TRH decrease, TSH decrease. Enlarging follicles regress and diffuse goiter reversed. So diffuse goiter is reversible. But if the follicles are enlarging because there was deficiency of iodine, so T3, T4 was not there, TRH, TSH was high. TSH is causing enlargement of these follicles. Now, if iodine is not supplemented or thyroxine is not supplemented, that means T3, T4 levels in the blood will be less. So TRH, TSH levels will be high. TSH is continuously causing growth of the follicles. A stage will come when these enlarging follicles will undergo necrosis, and necrotic follicles will unite to form a nodule. This can be a single nodule or there can be multiple nodules. Simple nodular goiter, multinodular goiter. Most commonly what we see is a multinodular goiter. Now, these patients, if we try to give iodine or thyroxine in a nodular goiter patient, then because these nodules have necrotic follicles, so T3, T4 will not be synthesized by them. That means this nodular stage is irreversible, and patient can present with pressure symptoms like dyspnea, dysphagia, or complications like secondary thyrotoxicosis and follicular thyroid cancer can occur in long-standing endemic goiters. Patient comes to us with a swelling in the neck. We can do ultrasound guided FNAC, fine needle aspiration cytology, where we can use 22 gauge to 26 gauge needle, and we'll come to know about this nodular goiter. If the patient was having any symptoms or complications or for cosmetic reasons patient wish, then we have to treat this story. Unfortunately, no medicine, no radio iodine will be able to help us because these are necrotic follicles. So, if patient has problems, then the treatment will be surgical removal. And depending on if only one lobe is having the nodules, we remove one lobe of the thyroid along with the isthmus, that is hemithyroidectomy. If both the lobes are having the nodules, then we do a total thyroidectomy. And whenever we are doing a thyroid surgery, patient should not be hyperthyroid at the time of surgery, because if patient's blood levels of T3, T4 are high and we take this patient for surgery, during surgery, surgeon is handling the thyroid gland, so there will be more liberation of T3, T4. Suddenly, during surgery, very high levels of T3, T4 can lead to thyroid storm or thyrotoxic crisis. So, a hyperthyroid patient should be made euthyroid before surgery, and for doing this, we can use various different type of medicines. Antithyroid drugs, carbimazole, methimazole, which should be given up to evening before surgery. Iodides, which gives additional safety by reducing the vascularity of the gland. They are continued up to morning before surgery. And if beta blockers are used to control hyperthyroidism, because they do not interfere with the synthesis of thyroid hormones, rather they have a peripheral action where they inhibit peripheral conversion of T4 to T3. So we should continue these medicines for 7 days after surgery. There can be various complications related to thyroid surgery, like respiratory distress can occur after thyroid surgery, which can be seen either inside the OT or within few hours after the operation or maybe few days after the operation. Reasons are different, treatment will be different. Inside the OT, if the surgeon has damaged both the recurrent laryngeal nerve, then when the anesthetist is extubating the patient, then the vocal cord paralyzed and sudden respiratory distress. So anesthetist has to put the tube again and the surgeon has to repair those nerves. Within few hours after the operation in the recovery room, that is because of reactionary hemorrhage. There may be slipping of a ligature from superior thyroid artery, maybe few hours after the operation, which will lead to bleeding. And this blood will clot and may create a clot compression over the trachea, leading to respiratory distress. The immediate step to be taken in these cases is open the skin sutures quickly, evacuate the blood, release the pressure on the trachea, and then the story becomes normal. After a few days of operation is because of hypocalcemia. So that will require calcium supplementation 2 to 5 days after the operation. Apart from respiratory distress during thyroid surgery, there can be nerve injuries, like most commonly it is the external branch of superior laryngeal nerve which can be injured. Recurrent laryngeal nerve can be injured. Total thyroidectomy, there will be hypothyroidism after the operation which will require thyroxine replacement for the whole life. Hypoparathyroidism can also occur after thyroid surgery, though it is rare. And the reason is ischemia to the parathyroid glands, because if the surgeon has ligated those branches of inferior thyroid artery which were supplying oxygen to the parathyroids, then hypoparathyroidism can occur. Sometimes parathyroid glands may be accidentally removed by the surgeon during operation, and if they are recognized after the operation, then we have to put them back either in the sternomastoid muscle if the incision is open, or if it is closed, then in the forearm or maybe in the arm. Primary, reactionary and secondary hemorrhage. Primary during operation, reactionary within 4 to 24 hours after the operation due to slipping of a ligature, dislodgement of clot and rise in blood pressure, and secondary few days after the operation, 5 to 7 days after the operation, and that is because of infection which causes erosion or sloughing of the wall of the blood vessel. Retrosternal goiter. This is simply enlargement from the lower pole of the thyroid gland behind the sternum, which causes compression leading to dyspnea and dysphagia. There can be stridor due to gushing of air through the vocal cords, or we can find engorged neck and facial veins because of compression of the superior vena cava, leading to pooling of blood in the neck and the veins. We can elicit a Pemberton's test wherein there is flushing of the face on raising both the hands above the head multiple times. And these retrosternal goiters can be removed just by a cervical or neck incision. The surgeon has to put the fingers behind the sternum, pop the retrosternal goiter in the neck, and this can be removed. No need to open the sternum to remove the retrosternal goiter. If we look at the basic anatomy of the breast is a modified sweat gland which lies between the two layers of the superficial fascia. The anatomical extent versus the surgical extent. Anatomically, breast extends vertically from second rib to sixth rib, horizontally from lateral border of sternum to anterior axillary line. But surgical extent is more in all directions. Vertically, second, it's the clavicle to 7 to 8 ribs, and horizontally from the midline to the edge of latissimus dorsi muscle. Some portion of the breast extends into the axilla, which is called as the axillary tail of Spence. And in the pigmented area around the nipple areola, there are sebaceous glands which enlarge during pregnancy lactation and serve to lubricate the nipples which are called as Montgomery tubercles. Nipple is a smooth erectile muscle tissue, that is why it is erectile. We can divide the breast into 4 quadrants. Like if this is the axillary tail, then this will be the upper outer quadrant, the upper inner quadrant, the lower inner quadrant, and the lower outer quadrant. Most common site of breast cancer is the upper outer quadrant, and the least common site of breast cancer is the lower inner quadrant. Lymphatic drainage of the breast. This can be divided broadly into 2 groups. One is the axillary group, which receives majority of the lymph, 80%, and 20% is by the internal mammary group. Axillary group can be divided into 3 levels. Lymph nodes which are lying below and lateral to pectoralis minor, level 1, at the pectoralis minor, level 2, above and medial to pectoralis minor, level 3. Anterior along the lateral thoracic vessels, posterior along the subscapular vessels, lateral along the axillary vein, central in the center of axilla, and apical, which are above and medial to the pectoralis minor in continuity with the lateral lymph nodes. These are infraclavicular lymph nodes. Lymph nodes which are between pectoralis major and minor, they are interpectoral lymph nodes or the Rotter's lymph nodes. 20% of the breast, especially the medial and posterior part of the breast, goes into the internal mammary. Congenital problems related to the breast: amasia, athelia, polymasia, polythelia, masia breast, thelia nipple. Amasia, if associated with the absence of sternal part of pectoralis major muscle, this is Poland syndrome, and this is more common in males. The site of polymasia is along the milk line extending from axilla to groin. Most common axilla, second most common groin. Mastalgia is breast pain. Now this can be cyclical and non-cyclical. Cyclical, which is related to menstrual cycle, which varies with the phases of menstrual cycle. Every female in the reproductive age group, the hormone levels are fluctuating. When the hormone level increases, there is hyperplasia of cells inside the breast. This causes congestion and pain. And when during the cycle the hormone level falls, there is involution of the hyperplastic cells and the story becomes normal. This keeps on going in every female every month. Young females, there is a possibility. In young girls, when their body is adapting to the changing level of hormones, when there is hyperplasia, they will feel congestion, breast pain. But it will vary with the phases of menstrual cycle. When the hormone level falls, involution occurs, the pain disappears. Generally, no active intervention is required for cyclical mastalgia. We just have to reassure these girls counseling is important. If by chance this cyclical mastalgia persists, then we can use various medicines like tablet of oil of evening primrose, reduces the congestion inside the breast. We can do hormonal manipulation using danazol bromocriptine, and the last resort would be tamoxifen, which is the hormonal therapy of choice in breast cancer in premenopausal females if estrogen progesterone receptors are positive. Because the game here is estrogen causing hyperplasia, so we can use tamoxifen. Tamoxifen is selective estrogen receptor modulator. Commonly what we see is the non-cyclical because of inflammations. So it is not due to hormones, so it is not cyclical. Now, inflammation of the veins of the skin of the breast, this is Mondus disease. Mondus disease. And inflammation of the breast is mastitis. This mastitis is mastitis. We are not seeing any abscess here. So it is just Ruber tumor, calladol, or functional mastitis. This is commonly seen during pregnancy and lactation. Now, in pregnancy and lactation, if the Montgomery tubercles are not able to secrete sufficient sebum, then there will be dryness in the mother's nipple. And if she does not use any external lubricating agents, the dryness will persist, which will cause cracks in the nipple. And because of the cracks in the nipple, when the baby takes the feed, then staph aureus from the baby's mouth can travel through the cracks in the nipple, go inside the mother's breast, and cause ruber tumor dollar functionalacia, mastitis. This stage can be treated by giving adequate antibiotics against the staph aureus and giving the adequate breast support. But if the lady is quite shy and she does not report to the hospital at the stage of mastitis, the staph party inside the breast, which is engorged with milk, continues. And this can form tiny, small abscesses inside the breast, tiny pus pockets inside the breast. If the lady comes to us at this stage, fluctuation will be negative, and ultrasound can show tiny pus pockets. This will require antibiotics plus multiple needle aspirations to aspirate these pus pockets under ultrasound guidance. If the lady does not come to us at this stage, or if the antibiotics are not working properly, then gradually a large abscess can form inside the breast. If the size of the abscess is more than 3 cm or it is more than 30 ml, then along with antibiotics, we have to do ultrasound guided catheter drainage, and we use a vacuum suction drain to drain these breast abscesses. Now, in these cases, fluctuation will be positive if there is good liquid collection. Earlier, we were doing NCN drainage, where the best NCN used to be radial. Cosmetic incision was circumareolar or periareolar. Discharges from the nipple. This most common discharge is milk, which is physiological. Most common pathological discharge is serous. Green discharge from nipple is associated with duct ectasia, blood discharge with duct papilloma and duct carcinoma. Duct ectasia is abnormal dilatation of the lactiferous ducts. And the story is, smokers, alcoholics, if they remain dehydrated, secretions of the glands become thick. And these thick secretions traveling in the duct, they will create traffic jam situations near the nipple in the duct, because of which the proximal duct is going to get dilated, and this is going to involve multiple lactiferous duct, and this can complicate to periductal mastitis or plasma cell mastitis also. Now, how these patients present? The commonest presentation in duct ectasia would be a green discharge from the nipple. However, this discharge can be bloody also. There can be slit-like retraction of the nipple. In breast cancer or ductal cancers, there is circumferential retraction of the nipple. There can be, because of stitches, there can be a chronic subareolar mass, which is called as Zuska's disease. Now, depending on how the patient presents, we approach accordingly. If there was a green discharge, no other pathology presents with green discharge, so the diagnosis is clear, no investigation needed, go ahead with the treatment. If there is blood discharge, blood coming out from any natural opening of the body should not be taken lightly, and we should do a cytological evaluation of the discharge to rule out malignant cells. We can do ultrasound of the breast if she is less than 40 years, mammography if she is more than 40 years. We can do a ductography or ductoscopy and make the diagnosis of duct ectasia and then do the treatment. If she presents with a lump, then lump in the breast, and if the age is more than 25 years, the standard guidelines are triple assessment, CRP, clinical, where we take detailed history and do detailed examination, or radiological, ultrasound less than 40, mammo more than 40, in high risk cases mammo more than 30, and P pathology, where we can do FNAC and we can do a ultrasound guided needle biopsy, make the diagnosis of duct ectasia and treat. Basic pathology in duct ectasia was blockade of the duct by the thick secretions. So we encourage the lady to take plenty of fluids and advise breast massage. This will dilute the secretions and help in removing the blocked secretions. This is the treatment of choice. If this fails, then we can try doing a microdocotomy, and if this also fails, then we have to excise the lactiferous ducts. Because ductictasia involves multiple lactiferous ducts. So excision of multiple lactiferous ducts, we have to make a conical incision, and this is head fields operation. If only single duct was having ectasia and it was not responding to conservative treatment or microdocotomy, then we have to excise a single lactiferous duct by a tennis racket incision, and that is microdocectomy. Duct papilloma, this is a growth from the lactiferous duct, and generally a single duct is involved and patient presents with blood discharge from the nipple. It is pre-malignant. If a single duct is involved and there is no ATPA, chances of cancer are less. But if multiple ducts are involved and there is ATPA, chances of cancer will be high. So treatment for duct papilloma will always be removal. That means if single lactiferous duct have to be removed, tennis racket incision, microdocectomy. If by chance there were multiple lactiferous ducts involved having this papilloma, then we have to make a conical incision to remove, and that is head fields operation. If we look at the breast lump like fibroadenoma and phyllodes tumors, the concept which we know, every female in the reproductive age group is undergoing phases, increased and decreased levels of hormones. When the hormone level increases, there is hyperplasia of the cells, and when the hormone level decreases during the month, whatever hyperplasia has occurred, that undergoes involution. So every female, every month in the reproductive age group, every month there is hyperplasia, involution, hyperplasia, involution. If by chance there is controlled hyperplasia and it persists, it does not involute, then it will result in benign tumor. But if the estrogen stimulation was more, then it will not be a controlled hyperplasia. There will be more number of mitosis and pleomorphism. So uncontrolled atypical hyperplasia, which can progress to carcinoma in situ and then to invasive carcinoma. Most common benign breast tumor is fibroadenoma. Most common breast tumor below 30 years of age is fibroadenoma. Most common breast tumor after 30 years of age is invasive ductal carcinoma. Most common benign breast disease is a fibrocystic disease of breast. Now, fibroadenoma, also called as breast mouse, it's a freely mobile lump inside the breast due to hyperplasia of a single lobule, usually seen between 15 to 25 years of age. Usually they are small, patients are asymptomatic, and they resolve spontaneously. If more than 5 centimeter, that is giant fibroadenoma, and complex fibroadenoma increases the risk of lobular cancer. Most commonly, patient presents with a nice soft to firm mobile lump inside the breast, no lymph node involvement, nothing. If the age is more than 25 years, then we do a triple assessment CRP. If the lady is older than 30-40 years of age, we can do mammography, and mammography gives a popcorn type calcification in fibroadenoma. Popcorn calcification on chest X-ray is seen in pulmonary hematoma. We can try giving some counseling and all because they can regress spontaneously by 30 years of age. We can try giving tamoxifen or meloxifene anti-estrogens to take care of that controlled hyperplasia. Results not very encouraging. What can be the indications for removal of these fibroadenomas? Generally, we wait up to 30 years of age. But if there is any suspicion on imaging or histology, or if the age is more than 30 years, or if the size is more than 5 centimeters, or patient's wish, or strong family history of breast cancer, then we should remove these fibroadenomas excision by periareolar or circumareolar incision. This is the circumareolar incision which we can make to remove these fibroadenomas, and this is what we are seeing suspicious on imaging. Here, if you look at this ultrasound, then it looks to be a nice smooth margins lump. But if you look at this ultrasound, then you find irregular edges like this. So, if it is suspicious on imaging, then yes, we need to remove these fibroadenomas. Cystosarcoma phyllodes is phyllodes tumor or serocystic disease of body. This is hyperplasia of stroma. This is generally seen after 30 years of age, and there is diffuse enlargement of the breast with variegated bossellated type of appearance. And on histopathological evaluation, we see a leaf-like appearance. And because it is leaf-like appearance, we call it as phylloides tumor, right? Because phyla means leaf. Now, if this becomes malignant, then it is sarcoma, and sarcomas does not spread by lymphatics. So lymph node removal will not be required in the management of these phylloides tumors. We have to do a wide local excision with a 2 centimeter margin along with the pectoralis major muscle. Treatment for all the sarcomas, whether it is liposarcoma, lymphangiosarcoma, osteosarcoma, malignant gist, or desmoid tumor, which is common in females below the umbilicus from the muscles aponeurosis of the anterior abdominal wall, will be wide local excision. Right. If we look at this endocrine surgery, thyroid and breast. Now, thyroid, goiter. Goiter simply means enlargement of the thyroid gland. Most common causes, iodine deficiency. Whenever iodine is deficient, T3, T4 will not be formed. Blood levels of T3, T4 will be less. So TRH, TSH will be high. And job of TSH is to promote the release of T3, T4 from the follicle and cause growth of the follicle. In iodine deficiency, because T3, T4 is less, TRH, TSH is high. So TSH will try to release T3, T4 from the follicle. But because T3, T4 is not formed due to deficiency of iodine, so T3, T4 levels in the blood will not increase. So TRH, TSH will keep on increasing, and TSH will cause growth of the follicles. If all the follicles are large, diffuse goiter. At this stage, we can give iodine to the patient or thyroxine to the patient. If you give iodine to this patient, then this iodine will help in the synthesis of T3 and T4. And T3, T4 levels in the blood will increase. So TRH, TSH will decrease. And if TSH decreases, the diffuse goiter will disappear. The follicles will regress. If you give thyroxine, then it will increase the T3, T4 levels in the blood. TRH, TSH will go down, TSH goes down, follicles will decrease, and the story becomes normal. Now, if suppose the follicles are enlarging and iodine or thyroxine is not given, that means T3, T4 levels in the blood will be less, TRH, TSH will be high, and this TSH will keep on enlarging the follicles. And a stage will come when these enlarged follicles can undergo necrosis. Necrotic follicles will unite to form a nodule. This can be a single nodule or there can be multiple nodules. Simple nodular goiter, multinodular goiter. Most common, multinodular goiter. If a nodule has formed due to those dead necrotic follicles, now supplementation of iodine or thyroxine at this stage will not help, because that will not be taken up. Iodine will not be taken up by those necrotic dead follicles. So, if a nodular goiter patient comes to us, he can come to us with some symptoms, maybe pressure symptoms, dyspnea, dysphagia, or complications like secondary thyrotoxicosis or follicular thyroid cancer in long-standing endemic goiters. We do an ultrasound of the neck, and ultrasound guided FNAC can show us. In the treatment, if the patient is symptomatic or there are complications, then because no medicine or radioisotope will help in treating this nodular goiter, so only option is surgery. If nodules are involving only one lobe, then we do hemithyroidectomy, remove one lobe with the isthmus. If nodules are involving both the lobes, then we do total thyroidectomy. Whenever we are doing thyroid surgery, patient should not be hyperthyroid at the time of surgery, because if T3, T4 levels in the blood are more at the time of surgery, During surgery, when the surgeon is handling the thyroid gland, there will be more liberation of T3, T4 in the blood, which can lead to thyroid storm or thyrotoxic crisis. So we have to make the patient euthyroid before surgery. We can use antithyroid drugs like methimazole, carbimazole, which should be given up to evening before surgery. We can use iodides, which gives additional safety by reducing the vascularity of the gland, so they are continued up to morning before surgery. If beta blockers are used to control hyperthyroidism before surgery, because beta blockers does not have a central action, they inhibit peripheral conversion of T4 to T3. So they should be continued for 7 days after surgery. There can be complications of thyroid surgery, like there can be respiratory distress, which can be seen inside the operation theater, or maybe few hours after the operation, or maybe few days after the operation. Inside the operation theater, because of damage to both the recurrent laryngeal nerve, anesthetist will not be able to extubate the patient, so nerves have to be repaired. Within few hours after the operation, due to reactionary hemorrhage, slipping of ligature on superior thyroid artery, which can lead to profuse bleeding, this blood clot may cause compression of the trachea, leading to respiratory distress, and this will require immediate opening of the skin sutures to evacuate the clot and release the pressure on the trachea. Few days, 2 to 5 days after surgery, can be because of hypocalcemia, and this will require calcium supplementation. Apart from respiratory distress, there can be nerve injury after thyroid surgery, like most commonly it is the external branch of superior laryngeal nerve which gets injured. Recurrent laryngeal nerve can also get injured. Hypothyroidism can occur after total thyroidectomy, which will require lifelong thyroxine replacement. Hypoparathyroidism can occur, but that is rare. That is because of ischemia to the parathyroids. If the surgeon has inadvertently divided those branches of inferior thyroid artery which were supplying oxygen to the parathyroid, will cause ischemia to parathyroid, causing hypoparathyroidism. Or sometimes parathyroid glands may be accidentally removed by the surgeon. Even if accidentally removed, they should be put back in any muscular area like sternomastoid muscle or the forearm or the arm muscle. Primary reactionary secondary hemorrhage, primary during operation, reactionary within 4 to 24 hours of the operation due to slipping of a ligature, dislodgement of clot, rise in blood pressure, and secondary after 5 to 7 days of operation due to infection. There is necrosis or erosion of the wall of the blood vessel. Retrosternal goiter is enlargement from the lower pole of the thyroid gland behind the sternum, can cause dyspnea and dysphagia, engorged dilated neck facial veins, and stridor. We can do a Pemberton's test, flushing of the face on raising both the hands above the head multiple times. This is Pemberton's test, and retrosternal goiters can be removed by neck incision only. No need to do a sternotomy. Breast. If we look at the basic anatomy, breast is a modified sweat gland lying between the two layers of superficial fascia. Extent of breast, anatomically vertically from second rib to sixth rib, horizontally lateral border of sternum to anterior axillary line. Surgical anatomy, vertically clavicle to 7th to 8th rib, horizontally midline to edge of latissimus dorsi muscle. Some portion of the breast extends into the axilla as axillary tailspins. In the areola, the sebaceous glands and large sebaceous glands during pregnancy, lactation, Montgomery tubercles. Nipple consists of smooth erectile muscles. Their breast can be divided into 4 quadrants. Most common site of breast cancer, upper outer quadrant. Least common site of breast cancer, lower inner quadrant. Lymphatic drainage of breast. 80% of the breast is drained by axillary lymph nodes, 20%, especially the medial posterior part of the breast, by the internal mammary lymph nodes. Axillary lymph nodes can be divided into 3 levels based on pectoralis minor muscle. Lymph nodes which are below and lateral to pectoralis minor are level 1, at the pectoralis minor level 2, above and medial to pectoralis minor level 3. There can be various subgroups of axillary lymph nodes: anterior along the lateral thoracic vessels, posterior along the subscapular vessels, lateral along the axillary vein, central in the center of axilla, and apical or infraclavicular in continuity with the lateral. Apical will receive efferents from all other lymph nodes. That is why apical lymph nodes involvement in breast cancer is considered advanced stage because we have to remove all the axillary lymph nodes if apical lymph nodes are involved in breast cancer. Interpectoral nodes or rotus nodes are between the pectoralis major and pectoralis minor muscle. Congenital problems in the breast, there can be amasia, athelia, polymasia, polythelia, masia breast, thelia nipple. Amasia is absence of breast if associated with the absence of sternal part of pectoralis major, that is called as Poland syndrome, common in males. Polymasia, multiple breasts, most commonly seen along the milk line, most common site axilla, second groin. Mestalgias can be cyclical, non-cyclical. Common, non-cyclical. Cyclical, which varies with the phases of menstrual cycle due to hormonal fluctuation every month, every female reproductive age group. When the hormone level increases, there is hyperplasia of cells inside the breast causing congestion, and when the hormone level falls, there is involution. Now, these cyclical mestalgias are common in young females, 15-25 years of age, and we have to do the counseling of these girls that there's nothing to worry about. Everything will become normal once your body gets adapted to these changing level of hormones every month. If by chance the girl is not getting convinced by reassurance, then we can try giving some tablets of oil of evening primrose, which can reduce the congestion inside the breast. Or at times we have to do hormonal manipulation like giving danazol, bromocriptine, and the last resort is giving anti-estrogen like tamoxifen. Non-cyclical mestalgia, which is quite common, like it is due to inflammation of the superficial veins of the skin of the breast and the chest wall is called as Mondus disease. Inflammation of the breast is called as mastitis. Mastitis is something which is very, very common, especially during pregnancy lactation, which can lead to breast abscesses also. Now, if the Montgomery tubercles are not able to secrete sufficient sebum to lubricate the nipple during pregnancy and lactation, and the lady does not use external lubricating agents, there will be dryness in the nipple persisting, which can lead to cracks in the nipple. When the baby takes the feed, then staph aureus from the baby's mouth can travel through cracks in the mother's nipple and go inside the breast, which is engorged with milk, and party inside the breast, leading to acute inflammation, river tumor, callodolar functionalacia, redness, swelling, raised temperature, and pain. At this stage, we have to give antibiotics to kill the staph aureus and give adequate breast support. If this treatment fails, or if the lady does not report to the doctor at this stage, and the party of staph continues inside the breast, there is a possibility that tiny, small pus pockets can form inside the breast. In these cases, sign of fluctuation will be negative. Ultrasound can show us multiple tiny pus pockets inside the breast. This will be treated by giving antibiotics and ultrasound guided multiple needle aspirations from those tiny pus pockets. If this also fails, and suppose the female does not report to the doctor, then this party inside the breast will keep on increasing, and a nice localized abscess can form inside the breast, where fluctuation will be positive and ultrasound will show a nice liquid collection inside the breast. If the size of this is more than 3 cm or volume is more than 30 ml, then under antibiotic cover we do ultrasound guided catheter drainage. A vacuum suction drainage is done. Earlier we were doing NCN drainage for breast abscess, like breast NCN used to be radial and cosmetic used to be periareolar or subareolar, periareolar or circumareolar. Why we don't make NCN drainage for breast abscess nowadays? One, it is going to give a scar in this relatively young lady, pregnant lactating lady. Second, we have to put a bandage to cover the breast after NCN drainage, so this lady will not be able to breastfeed the baby. And if we are doing ultrasound guided catheter drainage, the nipple will be away from that catheter, so the baby can easily take the feed. Breastfeeding should be encouraged even in case of breast abscess. If we look at the discharges from nipple, then most common discharge is milk, but this is physiological. Most common pathological discharge is serous. Green discharge from nipple is ductectasia. Blood discharge in duct papilloma or duct carcinoma. Now, ductectasia is basically abnormal dilatation of the lactiferous ducts. Usually multiple ducts are involved, and this is common in smokers and alcoholics who remain dehydrated. Because of dehydration, the secretion of different glands lose water, so secretions become thick, and when they're traveling in the lactiferous duct, they can create traffic jam near the nipple in the ducts, which will cause proximal dilatation. Because multiple ducts are getting affected, multiple ducts will be involved in duct ectasia. Stasis of secretions can lead to complications like there can be plasma cell mastitis or periductal mastitis. How these duct ectasia patient presents? Most commonly green discharge from the nipple. However, discharge can be brown, black or bloody also. There will be slit-like retraction of the nipple. Any pathology inside the breast involving the duct. Because ducts are converging at the nipple, so we find some or the other manifestation at the nipple. Like in breast cancer, we find circumferential retraction of the nipple. There can be chronic subarular mass or chronic subarular abscess, which we call as Zuska's disease. How to approach? If there is green discharge from nipple, no investigation, just treat the duct ectasia because no other pathology presents with green discharge from nipple. But if it is blood discharge, then bleeding from any natural opening of the body cannot be ignored. We have to do cytological evaluation to rule out malignant cells. If cancer cells are ruled out, we can do ultrasound of the breast. If less than 40, mammography after 40 years of age. We can do a ductography, ductoscopy also. If the lady presented with a lump inside the breast and if the age is more than 25 years, then the standard guidelines for breast lump after 25 years of age is triple assessment, which is CRP. Clinical, detailed history and examination, radiological, ultrasound less than 40, mammo after 40, high-risk cases mammo after 30. Pathology, we can do ultrasound-guided FNAC or ultrasound-guided needle biopsy. Make the diagnosis and treat the duct ectasia. Treatment of duct ectasia is very simple because the game is blockade of the lactiferous ducts by the secretions. So we advise these females to take plenty of fluids and advise breast massage. This will help in removing the traffic jam. If this is not helpful, we can try doing a microdocotomy. If this also fails, then we have to excise the lactiferous ducts. Because multiple lactiferous ducts are involved in duct ectasia, so to excise multiple ducts, we make a conical incision and excise them. That is Hadfield's operation. If only single duct is involved in duct ectasia and is not responding to fluids and massage, or to microdocotomy, then single duct has to be excised, making a tennis racket incision, and that is microdocectomy. Duct papilloma is an abnormal growth from the lactiferous duct inside the breast. Usually single duct is involved, presents with blood discharge from nipple, it is pre-malignant. If only single duct is involved and there is no atypia, then chances of cancer will be less. But if multiple ducts are involved, having atypia, chances of cancer will be high. Because this is pre-malignant, so we cannot ignore and we have to remove. Excision of single lactiferous duct by tennis racket incision is microdocectomy. If papilloma is involving multiple ducts, excision of multiple lactiferous ducts by conical incision, Hadfield's operation. Lumps inside the breast, every female in the reproductive age group, every month, there is fluctuating level of hormones. When the hormone level increases, it causes hyperplasia of cells inside the breast, and when the hormone level decreases, this undergoes involution and the story becomes normal. If suppose this hyperplasia persists, and if it is a controlled hyperplasia, it will result in benign tumor. But if the estrogen exposure was more and abnormal, then it will not be a controlled hyperplasia. There will be more mitosis pleomorphism that is going to cause atypical hyperplasia, which can progress to carcinoma in situ and then frank invasive cancer. Most common benign tumor inside the breast is fibroadenoma. Most common breast tumor below 30 years of age is fibroadenoma, but after 30 years of age, it is invasive ductal carcinoma. Most common benign breast disease is a fibrocystic disease of breast. Fibroadenoma, which is so common, it is freely mobile inside the breast, so we call it as breast mouse. It is hyperplasia of a single lobule. Usually between 15 to 25 years of age. Usually they are small, patients are asymptomatic, they resolve spontaneously by 30 years of age. If it is more than 5 centimeters, it's a giant fibroadenoma. Complex fibroadenomas can lead to lobular cancers. If suppose the girl presents with a lump inside the breast and the age is more than 25 years, then we should follow the triple assessment guidelines CRP. If the lady is say more than 40 years of age, and if we are doing mammography, popcorn calcification on mammography is seen in fibroadenomas. Popcorn calcification on chest X-ray is seen in pulmonary hematomas. We can try giving tamoxifen or meloxicam type of medicines, but generally they resolve by 30 years of age. Reason for removing the fibroadenomas would be if there is any suspicion on imaging or cytology, if the age is more than 30 years, if it is more than 5 centimeters in size, if patient wants, or if there is very strong family history of breast cancer, we have to remove these fibroadenomas excision by periareolar or circumareolar incision. Cystosarcoma phylloides or phylloides tumor or serocystic disease of Brodie. This is generally seen after 30 years of age. It is hyperplasia of the stroma and there is diffuse enlargement of the breast with variegated bosselated appearance inside the breast. Now this, if it is a stromal hyperplasia and if it becomes malignant, then it will not be carcinoma, it will be sarcoma. And sarcomas generally do not spread by lymphatics, so lymph node removal is not required in treating sarcomas. The treatment will be wide local excision with a 2 centimeter margin along with pectoralis major muscle. Whatever is the sarcoma, whether it's a liposarcoma, lymphangiosarcoma, osteosarcoma, Ewing sarcoma, malignant cyst, or maybe desmoid tumor, which is common in females below the umbilicus from muscle aponeurosis of the anterior abdominal wall, the treatment generally is wide local excision. Thank you very much for your patience, Veda.